Hello, good morning everyone. Assalamu alaikum, sabah al khair. The cardiac track is usually my favorite whenever I go to any conference until the lecture on pacemaker and ICD comes. That's when I usually take my coffee break. It's always dry and a bit rough, so thanks for staying. I'm going to go straight to the meat. I'm going to start by talking about the anatomy of the pacemaker. So a few things you need to know, and this is going to be very tailored for the emergency physician. So hopefully you'll pick up a few things that probably would help you, inshallah, would help you when seeing the patient. So what you see here, this is the pulse generator. It's basically that piece of hardware that has a programmable software and a lithium battery that has a lifespan of anywhere between 5 to 10 years. And then you have the lead, which is the component that actually transmits the electricity, and this is how it looks on X-ray. So this is very superficial description. I'm going to go into more depth. So if you look at this piece right here where the arrow is, this is the pin connector. Now this really needs to be attached and engaged to the pulse generator block. So this needs to be touching, and I'll show you a few examples later on of problems where this is not connected properly, and it's something an emergency physician can detect. Now, I have to tell you, this was, when I learned about this is one of the most exciting days for me, when I realized that I can actually differentiate between ICD and a pacemaker just by looking at a chest X-ray, and it's much simpler than what many people think. So if you see two large hyperdense coils on that cord, this is an ICD, okay? If it's one long, nice and thin lead, it's a pacemaker. So what's this? So just for the sake of simplicity, it's a single lead. You can see it. This is the pulse generator, and then you can see the lead coming all the way there. Is this an ICD or a pacemaker? So good. So this is a pacemaker. What about this one? So this is an ICD. Is it clear for everyone? Good. So if I leave now, I'm happy actually. So you see the two large hyperdense coils. So this indicates that it's an ICD. Good. So what's this? This one is a bit tricky. So who can tell me what this one is? So there's not one lead. So there's one lead in the atrium, there's one lead in the right ventricle, and there's another lead up here in the left ventricle. So first of all, is this an ICD or a pacemaker? So good. So it does have an ICD component because we see the big coil. So what is this? This is CRT-D. So it's cardiac resynchronization therapy -D because it has a defibrillator component. Some of them don't, so it's only a CRT, and we're seeing more and more of these after the FDA approval was sometime in 2001. So the indications are quite clear, but one of the class 1 indications, if you have an ejection fraction of less than 35 with a left bundle branch block with a QRS anywhere between 130 and 150 or over 150 actually, with New York Heart Classification 3 and 4. Clear indication, and we're seeing more and more of these. Good. So the last year of my training actually, I did an echocardiography fellowship in a very advanced, nice cardiac center. Where they had more assist devices, and that's where I got involved more in pacemakers, and I got a bit of interest in the whole pacemaker implantation and complications, and in the cath lab, that's where we were involved mainly in. This is the Royal Victoria Hospital in Montreal, and this is one of the entrances of the emergency department where I used to work. So the question is, what can we do in the emergency department to help these patients? So what's the first thing we do usually? We immediately jump to the ECG, but there are a few things that we need to do before. So this is quite practical. This is what I do when these patients come in, and I think it's a reasonable approach, and it's pretty much the recommendation. So the first thing is, you need to sit down and take a proper history. You need to take a cardiac history. You need to take a proper medical history. Is this patient a dialysis patient? Does he have renal failure, diabetes? All these things do matter. The indications for the cardiac conduction device, the initial indication, was it sick sinus syndrome? Was it AFib? Was it because of severe congestive heart failure. When was it done? Was it done 10 years ago? It does make a big difference to me. If it was done 10 years ago and the guy didn't have any follow-up, and now coming in because he's having symptoms of lightheadedness or not feeling well, probably it's a battery issue, okay? If someone came in with an implantation that was done 4 years ago and tells you that it was checked 2 weeks ago, so you know this guy is up to date, so probably you can look for something else or see if there's anything new happening. What type of device? Usually they have cards. Most of the time they know, and if they don't, there are ways to find out. We'll go over a few. Exposure to trauma. Was there any trauma? It's very important information that you can gather, that you can get from the patient, just by sitting down and asking the patient if he's awake and willing to talk. So was there any trauma? Was he exposed to any extremes of temperatures? Was he exposed to any electromagnetic fields? These are the questions that should be asked. Any pacemaker symptoms, any lightheadedness, syncope, chest discomfort, palpitations, we need to ask these questions, okay? So history is very, very key when assessing these patients. Now the second thing, just like a medical school approach, after history, we're gonna go to the physical examination. You need to expose the patient. You need to look at the area because you will be surprised. There are so many things that can happen at the location that can have detrimental effect on the function of that pacemaker. So to mention a few, so one of them, the one here on the top, this is pacemaker migration, and these guys actually present to emergency departments, believe it or not. You can have hematomas. Usually the hematomas are close to the time of implantation. It's not a long-term thing, but infection is rather common. It's, you know, it can be up to 10 to 15%. Especially in the first early on, and then later on it's around 2%. But you can see a lot of infection. You can see leads coming out. So things can happen. Exposure is extremely important. Now, if you do have an infection, even if it's a bit of redness at the site, it's a big deal. Okay, the evidence does say that if there are symptoms superficially, okay, the chances are that the leads are also infected. Matter of fact, the study did show that the intravascular part of the lead, 70-something was infected, or 79 was infected, and the extravascular, over 90% was infected. And I think I do have a slide. Good. So this is the paper. This was published in 2004. I'm going to read it. So regardless of the initial presentation, the intravascular parts of the leads gave positive cultures in 79.3. That's almost 80%. Additionally, 91.6% of the cultures of the extravascular lead, which is a bit unusual. I would expect the extravascular leads to be probably clean, were positive in 91.6% of the patients. So it is a big deal. We shouldn't be ignoring that site. Now the next thing, what are we going to look at? So after taking the history and physical examination, this is not in no like specific sequence, but go to the ECG. So there are so many clues in the ECG. So what is this? Okay, this is a normal AV sequential or an AV like a dual chamber pacemaker. So this is a bipolar. You will see two leads, one in the right atrium, one in the right ventricle. And what you can see here, you can see a pacer spike or a pacemaker artifact before the atrium, and then you see an atrial depolarization, and then you see one before the QRS, and then you see, okay? So this is pretty straightforward. So you need to understand that this morphology, this is how it should look like. If it looks anything else, probably there is something bad going on. So what's wrong with this image right here? So what's the difference between this one and this one in terms of patterns? So this one follows a very, very clear left bundle branch pattern. This is what's supposed to happen, right? So you have the lead that's going down and touching the apex. Most of the time, sometimes the septum, sometimes the apex, but the apex is the preferred site. And because it touches, the conduction is going to go to the other side, so you'll have left bundle branch block pattern. So what's going on here? If you have a right bundle branch, this is in most of the cases, in very, very like small percentage of the cases, this might be actually a normal variant, but ignore that small percentage. Let's go with common. If you see this, this is catastrophic. This really means that that lead went from the RV through the septum down to the LV, okay? So always look at the pattern. So ECG is very, very key. Just go over a quick case. And this is why I'm saying not every pacemaker patient that comes to the emergency, you pick up the phone and you call your EP, your electrophysiologist. There are so many things you can do before you do that. So you have a 76 female, came in with weakness, chest discomfort. She's a congestive heart failure patient on Lasix. She does have a pacemaker. These are her vital signs, okay? She comes in with an ECG like this, okay? Now you can see there are a bit of pacer spikes. There's a pacer spike here, pacer spike here. Honestly, I can't make anything out of it, okay? I don't know what kind of pattern. Is this a right bundle or a left bundle? It's really not clear. Any clues what might be the problem? So these guys are allowed to have pathologies, and the pathologies will show on the ECG like normal human beings, okay? So on investigating this patient turned out to have, so this is what we just said, this patient turned out to have a potassium of 8. Okay, so she was severely hyperkalemic. On taking further history, she was recently started on the Lasix. She was given potassium replacement. She miscalculated the dose, and she misunderstood the dose, and she was overdosing on potassium, basically. So this is what happened. Okay, so this is the ECG after doing corrections in the emergency. Up to this point, the cardiology was not involved, and probably rightly so. I don't want anyone to get me wrong and say, oh, I'm not going to call cardiology and be all macho, and it's not what I'm suggesting. All I'm saying is there are so many things you can do before you pick up the phone. Have a very low threshold to call them, but you can still do your part as an emergency physician, as a specialist in the field. So you can see that the image here is much, much better. Now you're seeing pacer spikes at least. You have to understand that electrolyte imbalance and specifically hyperkalemia will increase the threshold for pacing, okay? So 50% of the it's still better. We still see clear pacer spikes, but 50% of the pacer spikes are not conducting. But over here in this image, the potassium went down from 8 to 6.6. So there is progression. What about this one right here? Coming in, if it looks like one and it sounds like one, probably it is one, right? So this guy came in with chest pain. Okay, not looking so good. It does look like he has pacer spikes all over, but this is very, very significant. Now, I know this specific thing is probably on the controversial side, whether or not we can use the Scarbow criteria on pacemakers and left bundle branch block, but the evidence is clear. The retrospective studies that looked at it, and a few other reviews on the topic, they all say that in context, it is quite specific, especially if the ST elevation is more than 5 millimeters. So over here, it is more than 10 millimeters, okay? This patient doesn't need the EP. He needs to go to the cath lab, or he needs some kind of revascularization, okay? So it's just to go over this Scarbow criteria. I just to let you know, I was looking at this yesterday as well, just to see if there's anything new, okay? There is nothing new. They're still saying that there is a lot of specificity to it. If it looks like one and it sounds like one, and the ECG is suggestive, so it should give you a very significant clue. Okay, so this is the part that makes me always run away. The oversensing, undersensing, I find it to be sometimes a bit confusing. Let's just go over this real quick. So, pacer spike, capture. Pacer spike, capture. Pacer spike, capture. Pacer spike, failure to capture. Boom, that's it. It's failure to capture, okay? What causes failure to capture? Lead fracture. Lead displacement. Any breakage in the insulation of the lead. Okay, so these are the big ones. This is not our business. It's good to identify. This is for them to fix. Nothing much in the emergency. So what about this one? This one is atrial depolarization, ventricular depolarization, and boom, you see a pacemaker spike. What is this? Oversensing, undersensing. What is it? I'll tell you what's going on. It's quite simple, actually. This ventricular contraction is not being sensed by the pacemaker, and that's why it's giving you the spike. So this is undersensing, okay? It's undersensing. It is not sensing this, and it's giving you a spike. Now the question is, if it's giving a spike, why is there no QRS after that spike? Again, the answer is simple, because it's in the refractory period. It's right there. The best example for this is the toilet flush. Once you flush it, No matter how many times you press after that initial flush, there's no way you can get another flush, except in very high-end hotels, but that's it, okay? And I hate those because it's against nature, okay? So this is undersensing. What about this one? The only two proper ventricular contractions are the two on the end. Everything in the middle is whatever you want it to be. Muscular contractions, someone shaking, loud bass, it doesn't matter. So there's something that's causing these spikes to go, these little spikes to go up, and the pacemaker is oversensitive. So it's oversensing. It's counting these as real contractions, and that's why there's no contractions in the middle. Okay, so what they do, and I put this one on purpose, so what they do in the EP lab is, you see this line, the dotted line, what they do is they just raise it up a bit, so they decrease the sensitivity, they make it less sensitive.
4 minutes left.
Okay. So, so this is the oversensing. All three of them, it's lead fracture, it's lead displacement, or a problem with the insulation. I'll show you a few things, a few images for you to look at. This is one of the big ones that we should know in the emergency. Big one. The only one. Does anyone know what this one is? Just shout it out. PMT. This is pacemaker-mediated tachycardia. Okay? This is a pretty good one to know. Pacemakers should not run this fast. If they do run this fast, there is a problem. Okay? So how do you manage these? So just in terms of mechanism, this is exclusive for 2 lead pacemakers. Both of them, they make up some kind of a re-entrant pathology, and they cause this arrhythmia. So this is a pacemaker-mediated tachycardia. How do you treat this in the emergency department? Easy, but there's a lot of reluctance from our side to do it. You just put on the magnet. This is where the magnet comes in play, okay? The magnet is something that looks like this. Whoops. It's something that looks like this. You apply it, you slap it on, and you're done. Okay? It will go instantly. Matter of fact, if you keep the magnet on for a few seconds and then you remove it, it's done. It's just like giving a dose of adenosine for an SVT. If it breaks the re-entrant tachycardia, if it breaks the cycle, it breaks the cycle. Okay? Now, this is for pacemakers. Okay? It will just put it to a preset value anywhere between 70 to 100 or 80 to 100. Okay? So it's going to run at that rate. And this is what we see here. So pacemaker-mediated tachycardia, and then boom, you have normal spikes or normal rhythm after it, or that preset rhythm. If it's an ICD, if someone's coming in with multiple shocks, inappropriate shocks, you can put the ICD. It will just switch off that anti-tachycardia mode. So the last thing you should do is take a look at that chest x-ray. It gives you so much information, okay? Just you need to know the RA, the RV, the LV. So what's the problem with this image? So remember the connector pin I told you about? There is no connection between the lead and the pulse generator. The pulse generator, there is no connection. So this is one of the things you should look at. You should start from the pacemaker and just follow the lead all the way. Okay, and this is how, remember, this is how it should look like. You should have that connection. So what's the problem here? I wish there was no arrow. I couldn't find another image. This is a clear lead fracture. So it's a broken lead, okay? This one, you can see this is an ICD, as we mentioned earlier, and you can see that insulator is severed. There's a bit of a disconnect in that insulator, and electricity is inherently very weak, okay? It will just go to the pathway of least resistance. So nothing's going to go to that end where it's supposed to reach. And you can see sometimes it's extremely subtle. You can see here, probably not noticeable. If you're not looking for it, you won't know, okay? Almost done. And then, again, another example here. A very, very small, tiny, loss of that continuity of that lead.
Time out.
All right.
Thank you, Dr. Aref.
So I have my last slide. It's just my. So you can see this one is disconnect, and this one is the Twiddler syndrome, where people play with the. So this is my last slide. So this is the clinical pathway. So you have the history, obtain history and physical examination. The things in red are the things I added. You obtain it ECG and the chest X-ray, and then you follow that pathway. Okay, so if you do have a pacemaker malfunction on ECG, if no, this goes for interrogation. If they do have symptoms, if yes, if it's tachycardia, apply the magnet. If it's an ST elevation, you go that pathway. If you have any electrolyte imbalance, you correct the imbalance. Okay, I hope that was helpful. Thank you very much.